Hello again, everybody. Going to the next presentation and changing completely the subject. We're going to talk about peripheral nerves a little bit. And I chose this topic especially because we're a bit limited on time. So we're going to focus on entrapment, neuropathies, about the ankle and the foot. And for that lecture, we will take some time together to go through the anatomy of peripheral nerves about the ankle and the foot. And this will be MR-based anatomy, and we'll go together through some slides. And we're going to stop sometimes to show you the main anatomical relationships of these peripheral nerves. And this is really important. It's maybe more important to detect which kind of pathology is causing entrapment. If we know the anatomy and if we know the anatomical reports, and especially if we know which structures those peripheral nerves are innervating, especially in terms of muscles, we gotta be okay in diagnosing entrapment neuropathies. Of course, I will give you some insight on the normal findings in imaging and really show you briefly some new imaging techniques available on MRI to assess the peripheral nerves. And this is not only around the ankle and the foot, this is everywhere in the lower and upper limbs. And of course, I'm going to show you some examples of pathology leading to entrapment neuropathies. So we'll start with the anatomy, and we'll start with the tibial nerve around the ankle and the foot. So the tibial nerve has main branches around the ankle, which is the medial calcaneal nerve. It's fairly sensory nerve. This one, we have the medial plantar nerve, which is both sensory, provides both sensory and motor innervation. The lateral plantar nerve as well. And we have the inferior calcaneal nerve, which is actually the first branch of the lateral plantar nerve. It's not a direct branch from the tibial nerve itself, but it's a branch of the lateral plantar nerve. And I'm going to show you this when we go through slides. So this is the tibial nerve, just a drawing took from the literature to show you how it goes, its course actually around the ankle, especially around the ankle, and its branches, the medial calcaneal nerve, and both medial and lateral plantar nerves. And here is a schematic illustration about, okay, I'm glad the yellow is working. So these are the branches of the tibial nerve, or posterior tibial nerve, and how we see them about the foot. So let's go through axial slices, MRI slices to see the anatomy, and we're going to do that together. So here is our first axial slide. All those images are T1 weighted images without fat suppression, which is the best imaging for exploring the anatomy of these structures. So here we can find in the posterior medial horn of the ankle the tibial nerve. At this stage, many authors call it the posterior tibial nerve. You can also call it as a tibial nerve. This is a branch of the sciatic nerve, and its division happened just above the knee. But since we're talking about the ankle and foot, so we're going to focus in that area. So near the tibial nerve, we have the tibial vessels, the artery and vein. It's just medially, as you can see. It's an important anatomical relationship. And we're going to see other important structures as well, such as the flexor hallucis longus tendon and muscle laterally, and medially two other tendinous structures, which is the flexor digitorum longus tendon and the posterior tibialis tendon. At this stage, we are really at the proximal aspect of the ankle. We still have the deep aponeurosis covering all the structures, and this is an important anatomical landmark since we are in the superior aspect of the tarsal tunnel. And you're going to remember this anatomy when we're going to talk about the tarsal tunnel syndrome. So we follow through the axial slide is the tibial nerve, and you can see always the yellow arrow following the nerve. This is this small dot you can see here. Maybe it's better like this, and we're going to follow it, and following its anatomical landmarks and relationships until we get in here. So at this stage, something's happening. So we still see the tibial nerve here, pointed by the yellow arrow. I'm just going to zoom a little bit so you can see it better. So here is the tibial nerve, almost dividing in its main branches, we're going to see. But already we can see this very small dot posteriorly, which is the first branch of the posterior tibial nerve called the medial calcaneal nerve. And okay, so you can see there. So here we got the division, the main division of the tibial nerve. So anteriorly you see the medial plantar nerve, and posteriorly you see the lateral plantar nerve. So the anatomical relationships we're going to see and we're going to follow on the next slides will be always like this. So the most anterior, the medial plantar, and the most posterior, the lateral plantar nerve. And we still see the small dot posteriorly, which is the medial calcaneal nerve. And at this stage, we still see the relationship with the tibial, the posterior tibial vessels, artery, and veins. So we have the tibial nerve branches here in blue, as you can see. A relationship with the tibial vessels, artery, and vein. We still have medially the flexor hallucis longus tendon, and laterally the flexor hallucis longus tendon, and medially the flexor digitorum longus tendon and the posterior tibialis tendon. And at this stage, we're in the lower aspect of the ankle, we have the flexor retinaculum. So this is another important anatomical landmark I want you to remember further when we discuss the tarsal tunnel syndrome, because this is the inferior aspect of the tarsal tunnel. So we have lots of pathology occurring in this region, in this tunnel, that may lead to entrapment of the tibial nerve and its branches. So we still follow those. Again, anteriorly the medial, which is the yellow one, medial plantar nerve. In blue, in the middle, the lateral plantar nerve. In black, you see in black, I'm seeing in red, is the medial calcaneal nerve. But now we see another dot, this one, the green one. We see another branch, and this is the first branch of the lateral plantar nerve, which is here the medial plantar nerve, here's the lateral plantar nerve, the medial calcaneal nerve, we've seen it before, and now this is the fourth dot, the small dot we see is the inferior calcaneal nerve, which is the first branch of the lateral plantar nerve. And we're going to follow those through the slices. We always have here the vessels, medially, you can see. At this stage we see the medial plantar neurovascular bundle, surrounded by the tendons, flexor digitorum tendons and flexor hallucis tendons, as well as from some muscles, the abductor hallucis muscle. And here we can see on blue the lateral plantar nerve, in green the site of the inferior calcaneal nerve, and in red the site of the medial calcaneal nerve, just define the area, not the nerve itself. And the anatomical relationships, which is the abductor hallucis muscle and the quadratus plantae muscle. Coronal slides are tougher. It's more difficult to follow in this anatomy using coronal slides, but we will give a shot. So here's the tibial nerve, or the posterior tibial nerve. This is the most posterior slice that we're going to see, and we follow it here. Again, the anatomical relationship with the tibial vessels, artery and vein. You can see here, yes, this should be red, but it's in black. The tendons, the flexor hallucis longus tendon here, laterally. And we're going to follow those here. We have already the two main branches of the tibial nerve. So more superiorly, we're going to have the medial plantar nerve, and more inferiorly, we're going to have the lateral plantar nerve. And we can follow those on T1 weighted sequences very well because we have the signal of fat surrounding those nerves, as you're going to see here. Here is the vascular structures. We have some tendons, the same tendons that I showed you before, and we got to follow those nerves. So medial plantar nerve here, and the lateral plantar nerve here. And this is a very important anatomical landmark. I'm sorry about that. This should be red, and this is blue. I don't see if you can see it well, but this is actually simulating the course of the inferior calcaneal nerve, or the Baxter nerve. This is exactly the course of the nerve, and there are two potential sites for entrapment, and we're going to see that later. This one, where it changes its direction from vertical to horizontal between the muscles, the deep muscles, and this is the other one, just here, near the inferior aspect of the posterior calcaneal tuberosity, where we can have some entrapment as well. And I'm going to show you that later. So this is the medial calcaneal nerve, relating with the medial plantar vessels and the flexor hallucis longus tendon. And here's the lateral plantar nerve. We can follow those. If we see slice by slice, it's not that difficult. And the relationships of the lateral plantar nerve. So some muscles, abductor hallucis, quadratus plantae, and the flexor digitorum brevis muscles. We're going to follow them. We can follow them easily on slices. Here the medial, with some anatomical landmarks again, flexor digitorum longus tendon, flexor hallucis longus tendons, and some muscles, the same muscles as I told you before. Abductor hallucis, quadratus plantae, and flexor digitorum brevis muscles. And here we see the lateral plantar neurovascular bundle relating now with the plantar longus ligament superiorly, the quadratus plantae and the flexor digitorum brevis medially, and the abductor digiti minimi muscle laterally. And this is an important muscle we're going to see later regarding Baxter neuropathy. Again, we follow those. This is an important anatomical landmark as well when we're going to talk about medial plantar neuropathy. It's called the Henry's knot. It's exactly the site where the medial plantar nerve has its course underneath the navicular tuberosity. And this is a potential site of entrapment, especially in runners, and I'm going to show you that later. Sagittal plane is very difficult to follow those nerves. We can see something, and I'm going to show you. So here's the tibial neurovascular bundle, and here's the site where we see this bundle dividing exactly in this point, the black arrow, and we see anteriorly the medial plantar neurovascular bundle, and posteriorly and inferiorly the lateral plantar neurovascular bundle. And you can follow those here on the yellow arrows pointing the medial plantar neurovascular bundle with some anatomical relationships, same ones that I showed you before, and here posteriorly and inferiorly the lateral plantar neurovascular bundle. And we can follow those in the plantar aspect of the foot. Just to show you here, I did not point with an arrow, but this is also a very interesting site because the inferior calcaneal nerve, or the Baxter nerve, is exactly at this site, in the inferior aspect of the posterior calcaneal tuberosity. This is a potential site of entrapment as well. So the innervation patterns of these nerves, it's very important for us to know, especially the motor one. The sensory one is much more for clinicians. This is important for clinicians to define which nerve is affected while entrapment is happening. So this is the plantar aspect of the foot. So the medial plantar nerve will take care of this whole area medially of the plantar aspect of the foot, as you can see in yellow. The lateral plantar nerve will take care of the rest, mainly the lateral aspect of the plantar aspect of the foot. Let's see, yes, it's not displaying well. I'm sorry for that because it should be red. So this whole area here it's innervated by the medial calcaneal nerve, which is a branch of the tibial nerve. And the motor innervation, again, I excuse about the colors, it's not displaying the red. So this is the first muscle innervated by the tibial nerve itself, which is the flexor hallucis longus muscle and tendon, as well as the flexor digitorum longus muscle and tendon, and the posterior tibialis muscle and tendon. Those are innervated by the tibial nerve. For us, this is much more important because we're going to see the innervation pattern or the denervation pattern when we have entrapment. So we're going to see which muscles are affected while entrapment is occurring, and we can define by that which nerve is involved in each pathology. So for the medial plantar nerve, it's not a lot. It's not a lot to remind, to memorize. So we have this muscle here, the abductor hallucis muscle. We have this muscle here, which is the flexor digitorum brevis muscle. This another muscle you can see here, which is the flexor hallucis brevis muscle. Sorry. And the last one is the first lumbrical muscle, which is this tiny muscle here. So this is covered by the medial plantar nerve. And if we see pathology in those muscles, a denervation pattern, I'm going to show you what is acute or chronic denervation pattern. So we're going to suspect of medial plantar neuropathy. And all other muscles you are seeing, except the extensor digitorum brevis and hallucis brevis displaying the coronal slice. So this one here, quadratus plantae, the abductor digiti minimi, and all the other muscles, the adductor hallucis brevis. This is the abductor digiti minimi with the adductor digiti minimi, the other lumbricals, and the main interosseous muscles. All of those are carried by the innervation, the motor innervation is carried by the lateral plantar nerve. So what about the anatomy of the peroneal nerve? So the common peroneal nerve, its origin is with the tibial nerve, with the division of the sciatic nerve, and this is above the knee, just above the knee. The common peroneal nerve has three main branches. So the first one is the superficial peroneal nerve, carrying both sensory and motor innervation to the inferior, to the lower limbs. The deep peroneal nerve as well, and we have this branch here we not talk about in our lecture, is the recurrent articular branch. This is in the proximal leg. This is not about the ankle or the foot. So just to show you a drawing from the literature to represent the superficial peroneal nerve in yellow. So here is exactly the site where it's piercing the deep fascia of the lateral compartment of the leg, and then it has a superficial course through the ankle and the anterior aspect of the foot. And the deep peroneal nerve in blue, you can see its course here through the anterior tarsal tunnel, and I'm going to show you that. Let's see the axial images, the best ones to see the anatomy. So again, we have pretty much the same slice we started the other one for the tibial nerve. So here we can find this neurovascular bundle, which the arrow in blue, and this represents the deep peroneal nerve and the anterior tibial vessels, artery, and vein. And the anatomical relationships here is the extensor digitorum longus muscle and tendon, the extensor hallucis longus tendon and muscle, and the anterior tibialis tendon. And this is pretty much covered by, in different extents, by the extensor retinaculum. And here we're talking about the anterior tarsal tunnel. And this is an important anatomical landmark you should you should keep in mind when we talk about pathology. So again, here we follow the course of the deep peroneal nerve with the anterior tibial vessels. It's not difficult. We can see it easily on axial images. And here, just to show you a very small dot representing the superficial peroneal nerve. This is very difficult. It's very tough. And sometimes it's difficult to be sure that we're talking about the superficial peroneal nerve. It can be very small superficial vessels just near. The most important thing is to know the area that the superficial nerve covers in the anterior aspect of the ankle, and that is the area highlighted in yellow. This could be also a branch because it has lots of divisions going on in the superficial, the anterior aspect of the ankle. So all this area could be covered by the superficial peroneal nerve. So coronal slice is very difficult. We see the extensor tendons here, and we find here the deep peroneal nerve with the anterior tibial vessels as well, and we can follow them until its division. The deep peroneal nerve divides into a medial and lateral main branches. And here's the sagittal. Sagittal is not bad to find the deep peroneal nerve. So here's the extensor digitorum longus tendon. And here we find the neurovascular bundle with the deep peroneal nerve and anterior tibial vessels. We can follow those. Here is the extensor ilicis longus, just to give you some anatomic landmarks where we are. And this is the division. We have the medial and lateral branches of the deep peroneal nerve. The lateral is mainly the motor, responsible for motor innervation of the foot. And here's anterior tibialis tendon. So how about the pattern of innervation? So this is the dorsal aspect of the foot now, not the plantar aspect as I told you before. So the deep peroneal nerve is covering that area, highlighted in blue. And all the rest, basically all the rest is covered by the sensory innervations covered by the superficial peroneal nerve. How about the motor innervation? So the superficial peroneal nerve, no, that's okay. So superficial peroneal nerve covers proximally both peroneus, longus, and brevis muscles and tendons, as you can see here. And the deep peroneal nerve will give the rest of the motor innervation. So starting with the extensors, extensor digitorum longus, extensor ilicis longus, and anterior tibialis, as well as the extensor ilicis brevis and extensor digitorum brevis muscles highlighted in the coronal imaging on your right side. And to finish the anatomy, the sural and saphenous nerves, those are very superficial nerves, and they are mainly sensory nerves. There's no motor innervation implied here. So for us, it's very difficult. We cannot catch a pattern of entrapment for these superficial nerves. This will be clinically depicted. And what we can see, if it's someone or the physician or the patient feels something like a small nodule or a mass, then we're going to do some imaging to find out what's going on. So here it's representing the very complex course of the sural nerve in the posterior and lateral aspect of the leg and the ankle. And in blue, you can see the course of the saphenous nerve. It basically follows the course of the greater saphenous vein. So axial, again, this is very difficult to be sure which one is the sural nerve. If it's a small vessel, it is a nerve, it's very difficult. The most important thing is to know the region that is covered. So the saphenous nerve, you can see, is the medial and anterior aspect of the ankle, and the sural nerve will be the posterior and lateral aspect of the ankle. And we can follow this area. So here is this area highlighted in blue to show you where we can find the sural nerve, and this is the area highlighted in yellow where we can find the saphenous nerve. I'll skip this one. Okay, and the innervation is mainly sensory. This is for clinicians, not for radiologists. So the saphenous nerve, it covers only the very medial aspect of the foot, and the sural nerve, the very lateral aspect of the foot, posteriorly and anteriorly, as you can see in the illustrations. So, some of the normal findings we expect, and talk about some new imaging techniques. So, ultrasound, it's not bad, it's very good actually, to evaluate peripheral nerves. This is not all about the ankle and the foot, in the lower and upper limbs. This is actually an example from the literature of the median nerve. It's not even the ankle or the foot, it's the wrist. But just to show you the pattern, what we see as a normal finding, it's like a fasciculated pattern of the nerve. You see the nerve fibers here covered by this hyperechoic fibrous tissue inside the nerve, and we have this hyperechoic epineuron involving the whole nerve, and this is the normal aspect on ultrasound that we expect from peripheral nerve. This is a cross-sectional view, and this is a longitudinal view, and that's what we expect from a normal nerve. And this is just microscopy showing this pattern that we see exactly the same in ultrasound. Routine MRI is the best technique. That's what we're going to use on clinical basis, on routine basis, to depict such entrapment neuropathies. So what we're going to see here on T1, this is a axial T1 and axial T2 fat suppressed sequence, is that the signal of the nerve, morphology, and especially signal of nerve, is fairly similar to the signal of muscles, of the surrounding muscles. So this is a good reference that you can have to compare and to say, okay, this is a normal signal of the peripheral nerve. So compare with the adjacent muscles. Sometimes you can see this finding on T2 weighted or proton density weighted fat suppressed sequences. You can see that the peripheral nerve is slightly hyper intense compared to the muscle. And this is very often, this is not pathology. This is not pathology, so be careful. Take a look on the morphology. Of course, if you have gadolinium, take a look in gadolinium if you have enhancement or not. But what we see, if the morphology of nerve is normal, it's not a problem to have this slight hypersignal intensity on T2 weighted or fluid sensitive sequences on MRI. Very briefly, going through some new techniques. So the diffusion tensor imaging is being used now not only for the central nervous system, but also for peripheral nerves, also for muscles. We are trying to implement that for muscles as well. So basically this is diffusion. This is diffusion imaging, measuring the diffusion of water molecules along the fibers of the nerve. And we can have a bunch of parameters to evaluate, like the fractional anisotropy, and gives us some quantitative information about the nerve. We can even use that to produce some tractography images to reproduce the course of the peripheral nerves, as you can see in here. This is diffusion weighted sequence. And this is the so-called MRI neurography, which is also based on diffusion, but this is three-dimensional diffusion. And this is nice because it can reproduce three-dimensionally the course of the nerves. So it gives a nice overall of the morphology and the course of the peripheral nerves. Okay, let's go through pathology. I'm not going to show you all cases, all types, all sorts of pathology. This is not the objective of this lecture. It's much more to show you some pathology leading to entrapment regarding the anatomy we saw before. So the tarsal tunnel syndrome, it's affecting actually the tibial nerve and its branches at the level of the tarsal tunnel, as I show you in the anatomy. Of course, we have a wide spectrum of causes leading to entrapment, especially nodules or masses, cystic, solid. But just for you to know that in up to 40% of cases, we have clinical tarsal tunnel syndrome and we cannot find any lesion, any nodule, any mass, anything. And this is important to know. So the clinical features are represented by burning pain and paresthesia, especially at the end, the plantar aspect of the ankle and the foot, and usually it worsens with activity. And the patient tells you that. It worsens with activity. And of course we can perform the Tinel test. The Tinel test, we're gonna percute the tarsal tunnel and we're gonna reproduce the symptoms as we do this sort of maneuver. So this is it's positive when we reproduce the symptoms while we are doing the test. So very often we have a positive Tinel sign. And in most of cases, this is very important as well, the symptoms refer to sensory innervation. In very late chronic stages of disease, we can have some motor problems, but usually it's sensory. So I show you some cases, random cases, for you to see. This is a patient with tarsal tunnel syndrome, and we perform MRI, and in this case we found this cystic lesion within the tarsal tunnel. You see the relationship of the cystic lesion with the medial and lateral plantar nerves in the inferior aspect of the tarsal tunnel. And after enhancement, you see that the cyst, this ganglion cyst, is not enhancing, but we have some inflammatory changes surrounding the ganglion cyst. And these inflammatory changes are surrounding the tibial nerve branches within the tarsal tunnel. That's why this patient had tarsal tunnel syndrome. This is another example. Trauma can be the cause as well of tarsal tunnel syndrome. And this is a cause of a multi-fragmented fracture of the calcaneus, as you can see here, lots of fragments, and especially this one here going within the tarsal tunnel and leading to entrapment of the tibial nerve and its branches. This is another case, and this is not very usual to find. We find this often at the posterior lateral tubercle of the talus, which we call the stieda process, but this one is in the posterior medial tubercle of the talus. And what's the problem with that? It's because it goes directly through the tarsal tunnel, and this will compress the neurovascular bundle passing by that. As you can see here, we have some mass effect on the neurovascular bundle at the level of the tarsal tunnel. And I show you for the same patient a coronal T2 weighted fat suppressed sequence showing some diffuse edema pattern in the abductor hallucis muscle, indicating a acute or subacute denervation. And if you remember, this muscle was innervated by the medial plantar nerve. So we are sure that the proeminent posterior medial tubercle of the talus was compressing the medial plantar nerve within the inferior aspect of the tarsal tunnel. So medial plantar neuropathy refers to entrapment at the tarsal tunnel or distally to it, of course involving the medial plantar nerve. So remember the Henry's knot that I show you at the level of the navicular tuberosity. It's a usual site for entrapment. We can also have entrapment between the abductor hallucis and quadratus plantae muscles, as well as near crossing the flexor hallucis longus and flexor digitorum longus tendons in the plantar aspect of the foot. And of course we may have a wide spectrum of causes. One of those is the jogger's foot, it's known as jogger's foot. This is due to repetitive trauma to the medial plantar nerve, and is often seen in runners. That's why we have this name for the pathology. So it's often seen in runners with increased heel valgus and foot pronation. So remember the Henry's knot. This is a typical site for entrapment of the medial plantar nerve in jogger's foot. And I'm going to show you that. The clinical features of jogger's foot is heel and arc pain and some tenderness may happen. The Tinel signal may be positive as well. The test might be positive when we do exactly at this site in the Henry's knot, reproducing the symptoms. And we can see as well some numbness along the medial plantar aspect of the foot as a clinical feature. So, most of cases, we're not going to find anything in the medial plantar nerve itself, in jogger's foot. The nerve will appear most often as normal on MRI. What we're going to look for, what we're going to search on those images is the typical denervation pattern affecting the medial plantar nerve. And I told you this case, for example, is a runner, as a case of jogger's foot, typical symptoms, and we can see here the abductor hallucis muscle and the flexor hallucis brevis muscle they are both displaying edema, diffuse edema pattern within the muscle, meaning acute or subacute denervation, which is really typical for medial plantar neuropathy. This is another example, but the chronic one you can see here on this T1 coronal sequence without fat suppression. We have already a lot of atrophy going on in these muscles. So he's losing muscle. This is a chronic stage of denervation, including the abductor hallucis muscle, the flexor hallucis brevis, as well as the first lumbrical. So this is the typical denervation pattern of distal medial plantar neuropathy. And we can see here in the coronal T2 fat suppressed sequence, there are still some denervation, active denervation going on, since we have some edema, diffuse edema, and here is mainly the flexor hallucis brevis muscle. Another case of entrapment, and this is a typical case of schwannoma of the medial plantar nerve. So it's a very round nodule, well-defined and homogeneous signal intensity, displaying especially high signal intensity on T2 fat suppressed sequences. And most importantly, we can see for these very small schwannomas, what we see often is homogeneous and very important enhancement of the lesion after gadolinium administration. And here's another example of proximal medial plantar neuropathy. As you can see here, high signal intensity within the abductor hallucis muscle, meaning the typical denervation pattern of the medial plantar nerve, and we already see some atrophy going on. So this is more chronic denervation than acute denervation. So lateral plantar neuropathy refers to entrapment at the tarsal tunnel or distally to it as well. So the most common form of lateral plantar neuropathy is the inferior calcaneal neuropathy, which called Baxter neuropathy. It's the first branch of the lateral plantar nerve, and we're going to talk about it. We can have different locations of entrapment regarding the lateral plantar nerve, wide spectrum of causes, and we're going to focus on Baxter neuropathy, which is the way more common lateral plantar neuropathy we can see about the foot. So we have entrapment of the inferior calcaneal nerve. Remember, first branch of the lateral plantar nerve. So most commonly, it's associated, most commonly the entrapment occurs at the level of the medial calcaneal tuberosity because of spur formation or plantar fasciitis. I'm going to show you some examples. And sometimes we have repetitive microtrauma leading to entrapment as well. And we have different locations of entrapment. So remember, I told you this is the course of the inferior calcaneal nerve. So this is the first site of entrapment between the quadratus plantae muscle and the abductor hallucis muscle. And this is exactly where the nerve changes its course from vertical to horizontally oriented course. So and this is a very common site of entrapment because of that change. And here is the main site of entrapment of the inferior calcaneal nerve, which is the inferior aspect of the posterior calcaneal tuberosity. So plantar fasciitis and enthesitis causing inflammation at the plantar aspect of the foot may potentially involve the inferior calcaneal nerve and leading to Baxter neuropathy. This is a case of, and back to the inflammatory arthritis we talked in the previous slide, this was a case of reactive arthritis with a lot of enthesitis going on around the ankle and around the foot. So what we're going to see, more than looking for the nerve itself, look for, I tell you to search for the denervation pattern. This is the way, this is way most important than to search for the nerve itself. And the inferior calcaneal nerve, or the Baxter nerve, it innervates the abductor digiti minimi. So this is only one muscle. So this is very easy to diagnose. We don't have to look for several muscles or several denervation patterns, but only this one. So this is a normal abductor digiti minimi muscle. You can see here. on your right image. Those are coronal T1 weighted sequences, and on an image on your left, you can see a very important atrophy of the muscle, telling us that there is chronic denervation because of entrapment of Baxter neuropathy. And this is a CT showing you again chronic denervation of the abductor digiti minimi muscle with very important atrophy. This is basically replaced by fat. There is no muscle anymore. This is a chronic Baxter neuropathy. So this is another case different from Baxter neuropathy. For lateral plantar neuropathy that we can see distally, entrapment at the level of the tarsal tunnel or even distally to it. And this is the pattern. So we can see this is an acute innervation involving the interosseous muscles at the second and third spaces. You see a lot of edema going on in these muscles. And this is a more chronic denervation pattern of lateral plantar neuropathy. As you can see here, important atrophy of the interosseous muscle at the fourth space, as well as atrophy of the abductor digiti minimi and adductor digiti minimi muscles. So I'm coming to the end. Deep peroneal neuropathy can be seen as well about the ankle, and this is highly susceptible to injury at the anterior tarsal tunnel, and it can be by direct trauma, especially seen in athletes, as well as repetitive microtrauma, and that depends on the type of shoes, and this is especially for the ladies, the types of shoes you are wearing, and this may cause repetitive microtrauma and lead to deep peroneal neuropathy. When the entrapment occurs above the anterior tarsal tunnel, we may have both sensory and motor innervation problems, but when we have entrapment exactly at the anterior tarsal tunnel, we're going to have way more sensory denervation or sensory innervation problems, since the lateral branch of the nerve have already diverged from that level. So distally, always think about the Lisfranc joint. This is a very common site. Lisfranc arthropathy may lead to very distal entrapment of the deep peroneal nerve. So some examples to you. So this is important tenosynovitis of the extensor tendons. And remember, the extensor tendons, they have close relationship with the deep peroneal nerve. And you can see here some acute or subacute denervation pattern of the extensor extensor digitorum brevis muscle. And another example, this is a ganglion cyst, and this ganglion cyst happens to be exactly at the side of the course of the medial branch of the deep peroneal nerve. So we don't gonna find denervation patterns because this is a sensory nerve branch. Another example, so remember always about Lisfranc arthropathy, especially when we have hypertrophic changes, hypertrophic osseous changes with osteophytes. We may have entrapment at this level, and this is an example of a schwannoma of the deep peroneal nerve. And the superficial peroneal neuropathy, the entrapment here, this is not for our lecture. The entrapment is more common at the distal leg, so it's above the ankle, it's not about the ankle. Is exactly where the nerve pierces the deep fascia of lateral compartment, as I show you in the drawing. And very commonly it's happening with dancers because they often stretch the leg with plantar flexion, and that can often lead to injury to the deep fascia with muscle herniation. Entrapment around the ankle and foot may also occur, but it's rare, and we can have a wide spectrum of causes as well. So just to show you this example from the literature, I don't have an example myself. So this is a muscle herniation from a tear of the deep fascia. It's exactly at the course of the superficial peroneal nerve. And to end, I cannot end this lecture without talking about morton neuroma. This is another kind of neuropathy we can see, which we call interdigital neuropathy. So mortal neuroma affects the terminal branches of both medial and lateral plantar nerves, and it's caused, we believe, by repetitive microtrauma in the interdigital space or intermetatarsal spaces. And we see as well some scarring or fibrous tissue formation at the interdigital nerve, and this entraps the interdigital nerve and causes all the symptoms. It's way more frequent at second and third intermetatarsal spaces. Entrapment may also occur at the level of the transverse metatarsal ligament, which leads to neuroischemia, but it's a way more controversial mechanism of mortal neuroma. It happens often with middle-aged women, especially those wearing high heels and tight box shoes. So it's highly related to the kind of shoes the ladies are wearing, so be careful with that. And clinically, we see some tingling, numbness, and paresthesia, and often we see the Mulder sign, and that's why I like to perform ultrasound for that one, because we can reproduce this clinical sign while making ultrasound. So actually, we're going to take the heads of the metatarsals and we're going to squeeze those. And when we squeeze those first, we can produce pain in a patient with mortal neuroma. And second, we're going to take the mortal neuroma out of the intermetatarsal space. And it goes often to the plantar aspect of the forefoot. And we hear a click, and we even feel a click when we do that. And this is a very important clinical sign that we can reproduce while performing ultrasound. So one example to show you, a quick example. So this is an ultrasound. We can see the third and the fourth heads of the metatarsal bones. And we see this nodule, hypoechogenic nodule, fairly well defined in the plantar aspect of the forefoot. And this was there after I did that maneuver. So I got the Mulder sign while performing ultrasound. So we squeeze the heads of the metatarsal bones and the mortal neuroma will get out of the intermetatarsal space. And we hear and we feel a click. And this is the MR of the same patient. And this was only I asked her kindly to go to MRI. No need to MRI for that one. The diagnosis was made by the ultrasound, but just to have the images, the similar images we have here. So here is the mortal neuroma, T1 weighted and T2 weighted fat suppressive. You can see that the signal is not very high on T2 sequences, and that's because of the fibrous tissue or scarring tissue we find in morton's neuroma. Personally, I don't think we need to inject those cases. Sometimes it's useful to differentiate from intermetatarsal bursitis, but we're going to see that actually on T2 fat suppressive sequences. And with, okay, so just to show you here with that one, a last one for serial neuropathy. Again, these cases will come to us when the patient or the clinician feels something while examining the patient. Because the clinical diagnosis is clinical, it's not on imaging. We don't see the innervation pattern, there's no motor innervation. So this was a case of a serial neuroma. The patient felt a nodule, very small nodule. Those all are T2 weighted sequence with fat suppressive in the 3 planes. And this was actually confirmed by histopathology. And with that one, so I come to the end. So some take-home points. So you see we can have various cycles of nerve entrapment around the ankle and the foot. Very important and extremely useful is to know the anatomy and the innervation pattern, especially the muscles. They can tell us a lot where the pathology is happening. So muscle denervation pattern, this is very important. And routine MRI is still the most valuable, useful technique we maintain, and with that one I finish my presentation. Thank you so much.